Welcome, everybody. My name is Larry Hofheimer, and I am the chairman and founder of the Macular Degeneration Association. I'd like now to introduce our first speaker, who has performed for us on numerous occasions and is an eloquent, distinguished member of the Macular Degeneration Medical Board. He is Dr. Jeremiah Brown. He is a board certified ophthalmologist with more than 10 years experience in vitreoretinal as a vitreoretinal surgeon. He founded the Brown Retina Institute in 2010 and established a medical practice focusing on retina diseases, including macular degeneration. It's now my pleasure to introduce to you Dr. Jeremiah Brown. Dr. Brown.
Hello, everyone. It's great to have you take the time out of your busy schedules to listen and learn about macular degeneration. There is really a revolution that's happening now. I can't think of a more exciting time to be in ophthalmology because of all of the new treatments and research that's going on with macular degeneration. This presentation we're going to talk about today is really talking about what's new. These are the questions my patients ask me every day in clinic, or things like, I have dry AMD. Why isn't there anything for me? Why don't I get injections? Or would the injections help me if I were to get them? And what's new being, why do I have to have so many injections? And how long am I going to have to do this? And so I really wanted to give you an idea of all the things that are going on behind the scenes in terms of new treatments and research. We have another presentation that will be coming later this year that kind of really goes more into the basics of what is macular degeneration and what's the difference between wet and dry, and how did we get where we are now, and how did the treatments that we're using every day actually come to be. So that'll be something to look out for the future. But today we're going to be looking toward future treatments. So what does macular degeneration look like? So when you go in for your eye visit, your ophthalmologist or optometrist may look in your eyes and say, well, I see that you have signs of macular degeneration. And basically what they're saying is they can see these little yellow deposits. This picture is a picture of the back of the eye, and you can see the optic nerve, the round circle off to the side. The central vision is here in this right eye and here in this left eye. And you see all these little yellow deposits. These are called drusen. They're kind of a mixture of protein and fats and old cell parts and things that your body should be getting rid of and recycling, but it's building up in the retina. This can happen before you have any symptoms at all, which is why it is important to just have your regular eye exam to know what your risk is. Now, some people go on to get what's called the wet form, where there's leaking or bleeding in the eye, and blood vessels will grow in from a deeper layer, grow into the retina, and start to leak and bleed. And that can cause the scarring that you see on these two pictures, with all this blood right across the person's central vision. And then as the blood absorbs, it leaves behind a scar like you see in this right picture. Now, one of the ways that your doctor may help in the diagnosis of whether or not you have the wet or the dry is they'll use an instrument called an OCT. It's a scanner. It uses a laser light to bounce a light off your retina, and it goes to the different layers and bounces back to the camera, and the computer can produce an image of all the different layers of the retina. So right now we're looking at a side view of the retina, and there's a dip at the very center point of your vision. There's this bright orange layer down here, which we'll be talking about. That orange layer is a layer of cells that nurture and take care of the retina. And they're kind of a barrier between blood vessels that are down in this deeper layer and the retina that sits on top of it. So those little protein deposits start to build up right along this orange-red line. And that's sort of the beginning stage of macular degeneration. When blood vessels start to grow in, you can see what looks different here. That orangey red line now looks kind of wavy and irregular, and there's blood vessels growing up into this person's retina. you can see there's fluid under it. So the retina is kind of ballooned up and there's like a little pocket of fluid. So this is what we're looking for when we say that someone has the wet form of macular degeneration. The person would start to notice that things look distorted because you can see the retina looks distorted. So that's what's going to be the clue to the patient that something is not right, is looking for distortion. Now, everything changed when we learned why those blood vessels are growing into the retina. And there's actually a chemical, it's called VEGF, or vascular endothelial growth factor. So it's a growth factor, it's a protein that causes blood vessels to grow. And once it was found that this is what's causing these blood vessels to grow into the retina, several medications were developed that actually block that protein. So you can see their names here: Lucentis, Avastin, Eylea, Macugen. These are all medicines that can help block that chemical and stop those blood vessels from growing. Now, as kind of our overview summary, take-home point, so the difference between wet and dry is basically that people that have the dry form just have those little deposits in their retina, versus the people with the wet form actually have blood vessels growing into their retina. Other take-home points that we'll discuss in that basic lecture is that there are multiple genes, as well as whether you smoke and the foods you eat. All of these things add together to give you your risk for having macular degeneration and how quickly it will progress, depending on what gene you've inherited. So everyone's macular degeneration is not the same. There's more than 12 different genes that all give a little bit of risk. So depending on what form of that gene you have, whether you have the high risk form or the low risk form, and how many of those genes you've inherited, your macular degeneration may be very, very different from your neighbor's macular degeneration. So you may be wondering, well, why am I getting an injection every 4 or 5 weeks and they're just coming every 3 or 4 months and they're doing just as well as I am? And it's because everyone's macular degeneration is not the same. We do know that taking the AREDS2 vitamins help lower the risk of progression. And that's a recommendation that everyone should take those AREDS2 vitamins if you have what's considered the medium or intermediate level of macular degeneration. And then lastly, this vascular endothelial growth factor is really the thing that changed everything for people with wet AMD. You can see I threw in this picture of some greens on the side because there's some very, very good data that shows that eating more greens such as spinach, kale, collard greens, turnip greens, the green leafy vegetables, even if you've inherited the risk for macular degeneration, the more of that you have in your diet will slow the rate that it progresses. Also, having fish once or twice a week helps slow the rate of progression, even if you are destined to get macular degeneration. So now let's think about the future. Like, where are we going to go from where we are now? So I've got 2 pictures here that show kind of the end stage of both of those forms. So on the left picture, you can see there's like a cookie cutter area that's missing in the center portion of this person's retina. And this is the advanced stage of dry macular degeneration. You can see a few of these little yellow drusen, those protein deposits that we talked about before. But then there's this area where the retina is all thinned out. And this person basically has lost most of their central vision because of this. You can see that the retina around this area is still healthy and they have peripheral vision, but they can't see details. And if we could slow down the rate that this thinning happens over the years, we could preserve more central vision. And on the right side of the screen, you can see what sort of the end stage of the wet form. So after those blood vessels have grown and bled and leaked, and they form this sort of white scar, which gives the same basic result. You can see there's scarring, so the person will have very little central vision. Maybe they can only count fingers in front of them. They can't see any of the letters on the chart. But their peripheral vision, you see the retina all around here, their peripheral vision still is intact. And that's the case for most people, even in the advanced stages of macular degeneration. But if we could somehow slow down this progression of the dry, that would be a big impact on a lot of people. I put this graph up here just to let you know how complex this whole disease is, and not that I want you to remember or memorize or even worry about the names of these different proteins that are on this map, but what I want to do is introduce you to the idea of what really, when we get down to it, what is causing macular degeneration. And in 2006, two different researchers found that mutations in a certain gene account for about 70% of the risk of people who have macular degeneration. So there is this sequence of proteins that we all have in our bloodstream at all time, and they've evolved through evolution to help protect us against bacteria, viruses, other things that we come in contact with. And you can see all these different, C3, C4, C3b, C5. These are all in a sequence of one protein binds to another, which then leads to another protein breaking off, and then that binds to another. And then the bottom line of all of this is it helps our body create little holes or puncture sites in a bacteria or a virus or something that's trying to attack us. So it's a part of our immune system that helps fight infection. So this part of the immune system actually creates inflammation. The body gets inflamed due to the infection, and this is part of that inflammation cascade. Well, it was found that one of the genes that controls this or kind of modulates this and reduces it, controls the inflammation so it doesn't go out of whack, a change in that gene increases your risk for macular degeneration. It's a pretty amazing discovery. So that on some level in our retina, in that orangey red layer that we were talking about, there are cells that have this low level of inflammation that is causing this damage. And so that led to people thinking, okay, we've got all these potential targets. Look at all of these things on this map. Maybe if we block one of those or prevent it from binding with the next one, maybe we'll be able to stop the process of macular degeneration. So I'm going to give you the story of just one of those. There's several that are going through studies, several that have been through studies, but Apellis Pharma has a medication that's in trials right now. It's called APL2, and it blocks one of those proteins in that pathway called C3. So if you can block C3, then you don't get to the end where all the inflammation builds up. And then if you don't have the inflammation, hopefully you don't have these cells dying. So it binds to that C3 molecule, inhibiting its effect. And they showed in their phase 2 studies that the rate of that thinning of the retina, that cookie cutter area that you're seeing on that picture, the rate that it progressed was slower than the people who didn't get the medication. So this is now in phase 3, and we're going to be hearing some results in the next year about whether in a broad, large population in 2 different studies, whether we see the same benefit happening. But we're very optimistic, very excited. Hopefully this may be one of the first things that we have to treat people who have the dry form of macular degeneration. Now, no matter what we get as a treatment, it would be nice if we didn't have to give it so often. That's the challenge, is that when we put that medicine into the eye, your body metabolizes it, it breaks it down, and eventually there's none of it left. If we could have a way of keeping it in there longer, that would be very effective. That would be a great advance. Well, Neurotech is one company that's working on a little cassette. You can see this little thing that looks like a piece of rice sitting inside the eye here, this white bar here. And what it basically is, it's a little cassette that has many, many, many little cells inside of it. And this little implant has cells that have been programmed to make a specific protein. And you can have it make whatever protein you want within certain limits in terms of size. So let's say you wanted it to produce this new chemical for dry AMD. Maybe they would be able to just have this implant put in, and that might have to be replaced every few years, but they wouldn't have to get injections every month to keep their macular degeneration from progressing. So they're working on this as a platform for many different things. We can have it produce aflibercept or produce Lucentis or produce whatever we want. And so this is one strategy that's being worked on to try to make the burden on the patient easier. How do we replace that tissue that's missing? We saw that cookie cutter area of tissue that's missing. Stem cells are a way of being able to replace that missing tissue, hopefully. So stem cells are cells that are very early in their development, and they can, depending on what environment they're in, what chemicals they have in contact with them, they can develop into any other kind of cell. And so we can encourage these cells through ways that have been worked out through research to develop into those cells that make up the layer that protects the retina, that orangey red layer that we saw in the OCT scan. That's the layer that's having the damage. So if we could get these cells into the eye, here we have an image of a surgical procedure where there's a long, thin needle that's going in and being injected into the retina. And so if we could inject these stem cells under the retina to help replace the cells that have already been missing, maybe we can help regain vision or help delay the loss of vision for people who have that advanced form of the dry. So this has been done. There have been several rounds and different types of studies. Honestly, at the present time, we're not even sure what the best strategy is. Should we just inject them under the retina like this? Should we make a sheet of cells, very thin, make a little opening in the retina and put a whole sheet of cells in a nice orientation so they're all smooth and flat, and insert that under the retina? Would that be more effective? And then there's another group that's studying these stem cells can release growth factors that can just promote the cells that are still living to keep on living, to help them live longer. So maybe we don't even have to inject them under the retina. Maybe we can get some benefit just injecting them into the vitreous of the eye. And then they would help the cells that are under the retina live longer. So there are all of these strategies. People are definitely working on it. Sometimes my patients are saying, are they doing anything with stem cells? How come I never hear anything about stem cells? Well, yes, there's a lot that's going on. The challenge is we really don't know what the best strategy is yet. It's encouraging that we haven't seen anything where these stem cells just grow wild or create a tumor, or they seem to grow in a limited fashion. So that's encouraging, but we really need to hear the long-term results. And there have been some very unethical studies done where people were paying to get stem cells injected into their eyes and actually had damage to their retinas, retinal detachment, scarring, and other things. So let's just wait and let's hear what the studies show us. And but results will be coming out in the next few years. So now let's turn to the wet. So we have something that works. It blocks a pathway that stimulates blood vessels to grow. But what's new? Eye drops, there was a study looking at eye drops. And one of the questions many patients will have, why can't we just give this in an eye drop? Well, as of right now, with the current therapies and the current medicines we're using, not enough of the medicine gets back to the retina if you just give it as an eye drop. So you just don't get enough all the way to the back of the eye to actually stop the blood vessels from growing. So in the idea of doing the injectable strategy, we have new things that are coming along the old pathway that work similar to Lucentis, Eylea, Avastin. And then we have new pathways that are being looked at. And we'll talk a little bit about that. Oral tablets, even stem cells, maybe in terms of their producing chemicals that may help inhibit the abnormal blood vessels. All of these things are being looked at. Oral tablets, ideally, the reason we put these chemicals into the eye is because these are powerful chemicals. I mean, VEGF, the actual chemical that's causing blood vessels to grow, we don't want to stop that in your whole body, because if you get a cut, if you have a heart attack, if you break your leg, we want new blood vessels to come in and heal that tissue. And it's pretty amazing. It's the same chemical. The same chemical is used in our body, throughout our body, to help heal injury. It's just that when it's in the eye, and there's too much of it and you get abnormal blood vessels, the problem is that this chemical will cause bad blood vessels to grow into the retina, which damages your vision. So we really only want to block it in the eye. So for many of these strategies, it's not really something you would want to take as an oral tablet and have it affect your whole body. You want it just at the point where the problem is occurring. And that's why you don't see really research into oral tablets for many of these types of medicines. So in the injectable strategy, kind of along the line of what we've been doing. There is a new medicine. It was approved in October of 2019. It's called Beovu, and we're going to talk about that. There are some others, and there's a long list. I just picked a couple to put on this list, but there are some others. Now our strategy of what we're trying to do is see, we have effective medicines, but can we make them last longer? And there are different strategies at trying to make the medicine last longer in your eye so you don't need as many injections. So Beovu is the one that just was approved in October 2019. And you can see these are sort of a molecular picture of these molecules that we use every day. Eylea is aflibercept, Lucentis is ranibizumab, bevacizumab is Avastin, and then brolucizumab is this small single chain antibody fragment. So it's a small protein. It's actually smaller than the other three. And because it's smaller, they can pack more molecules in a unit of injection. So for every 10th or a half of a tenth of a milliliter, we can put more molecules of the medicine in that liquid than you can with the other three. And so that idea was this might give us a longer duration of effect. And it might block that VEGF protein better by getting more molecules in the eye. So what did they found? It was very amazing. So this was definitely a step forward. More than 50% of patients could get an injection just every 3 months in their first year of treatment. So most of the time with Eylea, Lucentis, Avastin, most patients aren't able to go that long in their first year. Most patients are still in maybe the 6 week to 8 weeks, maybe if they're doing very well in their first year. And that's about the limit of how far we push it in the vast majority of patients. But here we're in a situation where the majority of the patients are actually going 12 weeks in between their injections. So that's definitely a step forward. I just wanted to show you this graph because this was the head-to-head test when they did it, Eylea or aflibercept versus brolucizumab or Beovu. And what they found is basically this graph on the left-hand side of the graph is letters gained. So if you're going up on this curve, that means you're gaining letters. As we go across the bottom of this chart, it's months. So these are months into the treatment. So in that first year, you can see most people, they gain most of their vision in the first weeks of their treatment. So say the first 3 months, they gain the most vision, and then it levels off and maybe gains a little bit more as you go into the second half of the year, but kind of levels off. So the point of this graph is to show you that even those patients, though a large number of those patients were getting fewer injections, they achieved the same vision. One of these is the aflibercept line or Eylea. One of them is the Beovu line. And then there's 2 different doses of Beovu. And pretty much everybody achieved the same visual outcome, but the Beovu patients didn't need as many injections. And they had less fluid in their retina. When you did their OCT scans, you could see the fluid was going away better with Beovu. So that was exciting. That was truly exciting. But then after the medicine was out for a period of time, it started to raise the issue that it can cause inflammation. So any kind of inflammation in the eye, even a little ocular irritation with the eyes a little red, and maybe the person sees floaters and it's treated with eye drops and it gets better. Any type of inflammation was occurring at a rate of about 4% in the Beovu group versus 1% in the Eylea group. And then there's a very severe form of inflammation of the blood vessels called retinal vasculitis. Inflammation is actually within the blood vessel. You might even get the blood vessel to become blocked due to that inflammation, or have a retinal artery occlusion is what it's called. This was occurring in about 8 to 10 out of 10,000 injections. So that's a pretty small number, 8 or 10 out of 10,000, but it's a real number. I mean, if it's you, it can be devastating. I mean, you could have worse vision than you ever had or ever would have had from your macular degeneration if you had severe vasculitis and you had a retinal artery blockage. So this caused everybody to kind of just take a pause. And The problem is it's very hard to predict. You can't just look at person on day one and say, oh, this one is more likely to get the vasculitis, so we won't use it for her. So unfortunately, many times or almost every time, we don't know who's the person that's going to be more likely to get this inflammation. So most retina doctors will still use Beovu. I still use Beovu, but only in my patients after we've had a discussion about this. They understand there's this risk. And these are the patients where it's just been very hard to get their leakage under control. They may be people who are coming every 4 or 5 weeks and they're still fluid. Maybe every time we try to extend their interval, they're doing good at 4 or 5 weeks, we try to go 6 to 8 weeks, it starts leaking again. And maybe after several years of that, the person says, okay, let's try this. There's a 50% chance I may be able to go for months and I can't even go more than 4 or 5 weeks. Some people have decided, yes, I'll take that risk. And it works. It works very well. And those patients in whom it works are very happy. But there is this risk of inflammation. So everyone should know about that with the drug Beovu. What's another strategy? How about if we could put a little port in the eye that we might inject it once or twice a year, fill it with medicine, and then throughout the year, that port would slowly release medicine into the eye. So this is the port delivery system that's being developed by Genentech, and it's in its phase 3 studies. And what's happening is the medicine is slowly leaking into the eye. And let me show you some of these results. So in its studies, the median time, so half of the people were able to go 15 months before they needed to have the implant refilled again. And the refilling the implant is just done in the office. So that little port that you see in that previous picture, this little port is sewn into the eye here. You can see in this figure D, the port is inserted into the eye in a procedure in the operating room. And then the tissue covering of the eye covers over that port so you don't feel something there. And then in the office, that port can be refilled. So the median time, half the people were able to go 15 months or more before they needed it to be refilled. 80% were able to go 6 months or more. So this will be a definite improvement in what the burden is on patients right now. So be on the lookout. You'll be hearing more and more about this as time goes on. It's also important to note that sometimes these don't work out. There were studies looking at adding another type of medicine to one of the medicines we already have to see if a combination therapy would work. A couple of those studies did not prove benefit. There was no benefit to adding this new medicine, but there's one new one called faricimab, also being developed by Genentech. It's a single molecule, but it blocks 2 different chemicals. So one arm of this molecule blocks the same old VEGF that we've been talking about, just like all the other medicines do. But the other arm of the molecule blocks another protein called Ang2. Don't need to remember that. Just know Ang2 is the protein that is increased in the eye of patients who have wet macular degeneration. Also, it's increased in patients with diabetic retinopathy as well. But it's a protein that's associated and can lead to new blood vessel proliferation. So if we block that, it's another pathway of stopping abnormal blood vessels from growing. So what did they find? So in their phase 3 studies, which were just announced, approximately half of the people could be treated every 4 months in that first year. So we were talking about Beovu with about half the people going 3 months. Now we're talking about half the people going once every 4 months. And this is in their first year of treatment, after their first 3 loading doses, going every 4 months. That's pretty amazing. 3/4 of the people could be treated 3 months or longer in the first year. So, clearly this is going to be another step forward. And so I always talk with my patients and I tell them, what you're going through now is probably the most difficult period of macular degeneration treatment, because the medicines that we use now pretty much begin to wear off after about 30 to 40 days. But as time goes on, we're going to be having medications that have a far longer effect, and it is going to get easier. Here's another strategy that's going to help us, using gene therapy. Most of the time when we think about gene therapy, we're thinking about someone with a genetic disease and we're going to implant the normal gene to take over and replace that abnormal gene. In this case, we're going to use gene therapy to have the cells in the eye actually produce the medicine that we want to be injecting. So let's talk about this. So the way that we get genes into a cell is we use a virus. So a cold virus is the typical one that's used for all of gene therapy. And it's basically a virus where they've taken out the genes that the virus has that actually cause it to give you the common cold, for example. They take all those genes out, and instead, into this little protein capsule, they put the gene for what they want to have produced. So this virus will do what it's trained to do. It goes into, in this case, into the eye, and it attaches itself to a cell, and it inserts the gene to make a new protein. Instead of inserting the gene to give you the common cold, it's giving you the gene to make a new protein inside the eye. And we can have it make Eylea. We could have it make Lucentis. We could have it make Avastin. If it works and it works long term, you might not need any further injections for years, in theory. So they started this research project. One of the companies, there's several doing this. I'm just picking one so that we can focus our talk and have time to get through everything. This company, Adverum, they're injecting the sequence for Eylea. When they did their studies in non-human primates, they found that when they injected that virus with the gene for Eylea, it was being produced in the photoreceptors, the ganglion cells, the iris, cells all throughout the eye were now producing this protein, which is going to help prevent wet AMD from progressing. So this is basically saying what I just said, is that they're going to put the promoter, which makes that gene get produced inside the virus, and that gets inserted into the cell right here. And the cell starts to make that protein. So you're going to hear more about this because their early studies are showing, that we may be able to go years before people need a retreatment, because you're getting enough of that protein being made for years by just this one-time injection. So these studies are in progress. You're going to be hearing a lot more about this also. So now you're going to, up after this presentation, we're going to be talking about what's the future in terms of monitoring. Early detection is so important. What we find is that patients who are getting treated in one eye, because they're coming to the office so often and getting their treatments, and we of course examine both eyes, or we do the OCT on both eyes when they're there, that we can detect their second eye. If they're going to get wet macular degeneration in the second eye, we detect it much earlier than the person detected it in their first eye. When we start treating that eye early, many times that second eye remains with excellent vision. Many times that second eye is still reading, driving, totally functional, because we caught it so early. So the key to better vision with any of these treatments is catching it early. And this 4C device, I just wanted to put my 2 cents in to say that I agree that this is an important advance in being able to monitor yourself at home versus just using the Amsler grid, which itself is helpful. Looking at your Amsler grid and looking for new distortion on the grid is helpful, but this is even better. And Dr. Blemker is going to talk with us about this in detail coming up. But so this is something in terms of the future of monitoring from home. And so you're going to hear a lot more about that. What about the future for people who already have damage to the eye? My patients always ask about, well, what about an implant? Can't we do something like people who are deaf? Some deaf patients are able to get a cochlear implant. Why can't we do a retinal implant? Well, a retinal implant has been developed, and it actually has been used for patients with retinitis pigmentosa. That's a severe hereditary blinding disease. And it does actually work. I mean, it helps people see the difference between light and dark. to be able to tell a sidewalk versus the road, to be able to see your white plate on a dark background. And it's basically a camera that sends a image to a transmitter, and then that information is sent forward to the implant that stimulates the remaining healthy tissue in the retina, and you get an image. And so the challenge with this is that it's early. It's in the early stages of this. The level of vision that you get from it is pretty basic. You know, for someone who is completely blind and can't see light versus dark or can't see a doorway, this means something. For someone who has some peripheral vision and can get around and they can see the doorway, they can see the chair in front of them, this is not really going to give you good enough vision to be really helpful in your daily life. But as all technology goes, it gets better and better as time goes on. So this may be a future for people who have severe blinding diseases, but it's not really something that I would recommend for someone with macular degeneration. There is an interesting device, which is a little telescope that helps magnify for people who have scars in both eyes from end-stage macular degeneration. So when people have cataract surgery, their natural lens of the eye is removed and a little implant is put into the eye, a lens implant that basically does the job of focusing light for your eye. Instead of putting a regular cataract lens implant, this little telescope can be put in the eye for people who have scars in their central vision. And so it's similar in terms of the placement of placing this into the bag of the eye here, where your normal lens implant would go if you were having traditional cataract surgery. And it sits here. This is on a cutaway view of the eye. You can see it sitting at the center of the pupil. And if you look at someone, you can kind of see it right here, this reflection right at the center of his pupil. That is the little telescope implant. So what does it do? It magnifies everything. So in this example here, where you can see this patient is looking at the word cat, and they're seeing the letters are falling in focus on their retina, but it's falling in one of those thin areas. So basically, they're missing that part of the word. And many patients with macular degeneration have this sensation many times where they get the sense where I can see the beginning of the word, I can see the end, but I can't see the letters in the middle. And that's because the word is falling on one of these gaps in your retina where maybe there's a thin spot that's no longer working. Well, if we magnify the image, you can see here with the telescope, now the image is larger than the gap in your vision, and it's easier to make out what that word is. So that's the theory behind this. In reality, it's something that is hard to get used to. So it takes a certain kind of patient. It's maybe a third of all people who can deal with the aspect of, number one, you're going to be walking around with this all the time. So not just when you're reading, it's going to be on when you're walking around, when you're riding in the car. One image is going to look big, the other image is going to look smaller. Also the sense of, you know, how when you're using binoculars, you can't really see around the image as well. So you don't have as much peripheral vision with this. So it's like having a binocular inside your eye, basically, and you can't really turn it off. You can close your eye, but you can't turn it off. So there are some people who are just very motivated. They're go-getter type of people. They're people who like to try new challenges. And for someone who's counting fingers in both eyes and they would like to try something like this, I would say go for it and see one of the doctors that does this implantation, and they go through a series of testing and things to see if you would be a good candidate. But this is not for everyone also, and not everyone can adapt to that difference of vision between the two eyes. So what do you do when you have lost vision? So not everyone is caught early. Not everyone gets good vision in both eyes. People still do lose vision. And what do you do? So number one, definitely seek out a low vision specialist. There are many things that can help you use the vision that you do have better. Monitor for depression. I mean, no, it is normal to have depression when you're going through understanding that you feel like you're losing your vision. It might be appropriate for you to take an antidepressive medicine. Maybe you want to go to a support group. people will get together and they'll talk about all the things that they deal with. You know, how do you deal with it when you're at the airport by yourself and you've got to find your way to the gate? Or how do you deal with it when you've got to do this or that? And just getting together and talking with someone every other month at a support group can really help lift your spirits. Register for disability. Know that there are programs out there that may be able to help you get some of these devices with much less cost if you've registered for disability in your state. So know that these programs are out there, and don't just go into a shell and give up, because there is hope. There is hope. So in summary, I hope I gave you a little idea of, sometimes it seems like there's not a lot going on, but there is a lot going on right now. This is an exciting time in ophthalmology. We're trying to prevent the blindness and wet macular degeneration, preventing the blindness in patients with dry AMD. We're getting newer and better imaging devices. Our OCTs are getting better every few years to help us understand the disease and identify abnormal blood vessels earlier and quicker. Understanding the genetics of macular degeneration to understand how to best treat our patients, which patients respond better to which therapy, which people are more likely to get the dry, which people are more likely to get the wet. Wouldn't you want to know if your risk of getting the wet was 70% in the next 10 years versus someone else, maybe their risk is only 5%? Understanding that macular degeneration is not just one condition. It's many different conditions. So our goal is to find the best treatment for each patient. And depending on what you've inherited, depending on whether you smoke, your course is going to be different from how macular degeneration may present and progress in your neighbor who also has the same disease. And then lastly, what do we do for the people who already have damaged retina? It may be stem cells, it may be other growth factors that can help the remaining retina work better or replace the damaged area. So I just wanted to say thank you. Thank you for taking the time. Thank you for taking the time to learn about this. And I appreciate your attention. So the first question is about where do I find information about these clinical trials? Someone who wants to participate. There is a website called clinicaltrials.gov where all the studies that are going on that have registered are listed. You type in your condition, and then it will list a whole long list of all the things that are going on, and there's contact information. Another good person is to talk to your retina specialist that's taking care of you and ask them, do they know of any trials? Anyone in our city that's doing a trial on this or that? Ask your general ophthalmologist, your optometrist. They may know of trials that are going on, but clinicaltrials.gov is a good source. One person asked which injection is better. I'm getting injections every 4 weeks and I'd like to go longer. It's really individual. So I wouldn't say that there are some people who do well on all of the injections. So I would ask your doctor who's taking care of you, I would pose it to them, you know, I would like to see if I can go longer. Is there another medication that we could try? Because there are 3 that are active right now. Maybe you've been on the same one for a long time. Sometimes a switch can help. And I've definitely seen cases of that where switching at some point can help. But really, I think what's going to be helpful to you are some of these new ones that are coming out, because the amount that switching medicine helps currently is small because all 3 of them work so similarly. Let's see. This is a great question. The person asked, they said, my dad lost a lot of vision due to macular degeneration. At times he says he's seeing people and things that aren't there. So there is this interesting phenomenon that's called Charles Bonnet hallucinations. When you have a gap in your vision, an area that's not functioning well, your brain can start to fill that gap with images. So I've had patients tell me they're seeing little candy canes, little faces, little trees. Everything looks blue, everything looks purple. It may last for a few months, and then for some reason, it just kind of goes away. And the person is not going crazy. They're not having a mental breakdown. It's just that your brain is just trying to fill in the gaps in your vision. It's almost like phantom limb pain, you know, when someone loses their arm and they can still feel that their arm is there and it almost feels like it's hurting even though there's no arm there. It's similar to that. But I would encourage the person to be able to talk about it and not feel like they're going crazy because of that. Now, one other variant of that, because I wanted to say one other thing, because I've also had this happen where, say, the person is getting, real hallucinations. The difference is what they're going to say is, I'm seeing images walking. Like this little boy who comes in my bedroom every evening, he comes to the side of my bed and then he walks away. That's not what I'm talking about. Like, that could be an effect from a new medication. It could be something that's happening in the central nervous system. So if it's like a formed image that's moving in your field of vision and doing things, and that's not the Charles Bonnet effect that we were talking about before. That could be a true hallucination, and that should be discussed with your primary care doctor. One person asked, why do the injections hurt? There are multiple different ways of numbing the eye, and different doctors do it differently. My feeling is, my philosophy, the injection should not hurt, so we have to keep trying new things to do to get it so it doesn't hurt. Some patients do well with actually injecting a little anesthetic after numbing the surface of the eye. We inject a little anesthetic in that spot where it's numb, and just inject it right on the surface and let it sit there for 10 minutes, and then they don't feel anything. So there are different ways. I would just encourage you to talk with your doctor, saying, is there another way we could numb my eyes? Just keep that communication open with your doctor. Let's see. One question is that they were diagnosed with macular, and they're wondering, they notice that their eyes are red and itchy a lot, and they're wondering if that's due to their macular degeneration. And that is not due to your macular degeneration. So macular degeneration is painless. It doesn't cause any effect on the outer layer of the eye. So redness, itchiness on the outer surface could be something else, could be allergies, could be dry eyes, could be something else. So you should definitely ask your eye doctor to take a look at your eyes and see what's causing that. One person asked about the COVID-19 vaccine. Is this going to cause my eye to get worse? Is it safe to get the vaccine? So far, and thousands of patients have gotten the vaccine, we have not seen any negative effects from the COVID-19 vaccine on the eye, or macular degeneration, or any other eye diseases at this time. So I don't think that, don't worry about your macular degeneration getting worse, and don't let that hold you back from getting the COVID-19 vaccine. And then another person just asked about the stem cells, which we touched on. And so the answer is, the research is going, it is ongoing, as we mentioned. The cells can be injected in these different ways. They do live in the eye. We really don't have the data to say that it's improving anybody's vision. That data is not there yet. So there are different strategies of how to inject it into the eye, and that's being worked on. But I would say right now, we really don't know if that's going to be a meaningful strategy, but it is actively being looked at. I would say it that way. Then another person mentioned that after they get their injections, their eyes are very red and itchy, and they get some swelling after the injection. The main thing I would say that I encourage all my patients to do on the day they get their injections is to use artificial tears every hour or two, all through the day. That can help. Another thing, encourage the technician that's working with you in the room that day to make sure that they're rinsing your eye very well at the end. Sometimes it can be just irritation from the betadine, which we use to prevent infection, which is very important. We don't want you getting an infection in your eye. Sometimes it's just from the Q-tips or cotton that's put in the eye with the anesthetic to help numb the eye. And then some people are actually allergic to something, if you're getting a lot of swollen eyelids and severe itchiness, it could even be that you're allergic to one of those different things. And so, mention that to your doctor. Make sure you're using lots of artificial tears on the days of your injection, and also encourage them to rinse your eyes very well after the injection. Well, thank you very much. I appreciate spending this time with you today, and look forward to future lectures.
So now Dr. Megan Blinker is going to be our next speaker. Dr. Blinker is a ocular disease residency trained optometrist who practiced in Nashville for more than 9 years before she transitioned to industry. She's currently works for Nodal Vision, has a little over 2 years where she serves as their Director of Clinical Affairs. It's now my pleasure to introduce to you Dr. Megan Blenker.
Perfect. And thank you also, Larry, for sharing your personal eye health story, AMD, and talking about 4C Home. Of course, we're going to get into a little bit more with the details on that. But thanks to you all for attending. It is such a privilege to be here, and I really appreciate the opportunity to speak to you all. And I'd just like to reiterate some of the really important points that Dr. Brown made in his presentation. I agree, he always has phenomenal presentations. I always learn something new from him, and look forward to the lectures that he gives. But at the moment, I'd like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. So the 4C Home AMD monitoring program is actually FDA cleared and Medicare covered. It is prescribed by your eye care professional whenever you have the appropriate level of vision and the appropriate stage of age-related macular degeneration. And it's a form of personalized medicine. So this device is actually used at home in between your regular eye exams. And the way it works is by detecting metamorphopsia or visual distortions that take place in AMD. And as we touched on before, AMD is the leading cause of severe central vision loss in people over the age of 50 years in the United States. I'd like to share with you the information you need to get informed and take charge of your vision, because this is a chronic, meaning it doesn't resolve or doesn't go away, and progressive condition, meaning it tends to worsen over time. And there are two types. There's the dry kind and the wet kind. And the dry type of AMD is the slower changing or earlier form of the disease that puts you at risk for developing the later stage or the wet AMD. And then wet AMD is that sudden change or more advanced form of AMD. Here you'll see some images that show you with what AMD affects as far as the retina. It's called the macula, which is responsible for your detailed central vision. Use this for activities like reading and driving and seeing other people's faces clearly. And in dry AMD, what happens, as Dr. Brown had mentioned, these changes occur in the cells of the macula here called drusen, these yellow spots or deposits that you see here, and they build up in the area. And then what happens with these changes is they actually induce blurry vision, and that makes it difficult for you to see sharp details both up close and far away. And again, because dry AMD is the slow form of the disease, you may not notice changes over time if something happens as far as symptoms or changes in your vision. And more importantly, as we'd said, that dry AMD form puts you at risk for progressing to the wet form of AMD. On these images here, you can again see the drusen on the left side of the screen. That's this yellow spots. And over time, the size and number of these deposits can actually increase, which increases your risk of developing this more sight-threatening form over here, wet AMD. Again, dry AMD can suddenly change without any kind of notice to the wet form. And if you convert to wet AMD, these abnormal blood vessels, so you'll see on the right side of the screen here, these abnormal blood vessels actually grow under and into the retina, into this macular area. And then they can leak fluid and they sometimes bleed without any type of warning. Again, you may not notice these changes until, unfortunately, significant vision loss has taken place. And if you convert to this form of wet AMD, this can be rapid and severe. Some symptoms include distortion, where you have straight lines that look wavy. You can have dark spots in your vision or just generalized blurry vision like you'll see on the screen here. And as Dr. Brown mentioned, there are some wonderful, wonderful treatments for wet AMD. But these treatments, as he said, are most effective whenever they're administered early on before you notice symptoms and before advanced vision loss has taken place. So they can halt or slow the progression of wet AMD, but unfortunately they can't restore the vision that's already been lost, because once the wet disease starts, it'll continue to advance until you receive your treatment. And then again, this irreversible damage can occur even within days or weeks before you notice any type of symptoms. But when I say early, then how early is that? Well, once those symptoms are noticed, those wavy lines or dark spots or the distortion, then your vision loss may have already occurred. And again, the earlier you catch wet AMD, the better chance you have of preserving your vision, You can preserve then your independence and just your ability to go about your daily life participating in all kinds of activities that you enjoy. So again, to summarize, wet AMD treatments are most effective when the disease is caught earlier. Here's an image of the 4C Home device on the left side of the screen. This is an early warning system for your eyes, and you use this device at home in between your regular eye exams. It helps with the detection of dry AMD to wet AMD before you even notice that any of those visual changes may have taken place. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision. It takes just a few minutes per eye per day. And then that information or that data from each test is sent to your eye doctor, as well as our No Television Diagnostic Clinic, which is the medical provider of 4C Home. And if a change in test scores is detected, then our diagnostic clinic alerts your doctor, and then your doctor's office will contact you to schedule a follow-up visit for examination, have you come into the office. Dr. Brown also mentioned the Amsler grid, and many of you may be using this at home. This technology or this grid was developed in the 1940s and has for a long time been recommended as a simple and very accessible tool that you can use to monitor for changes in your vision. However, by the time you notice the vision distortions on the Amsler grid, significant vision loss may have already occurred. So fortunately, new technology such as our 4C Home AMD monitoring program has been developed so you can detect these tiny changes before symptoms are noticed, and then the technology will report them to your doctor so that you can come in for that immediate examination. Testing with 4C Home is very easy. You simply turn the device on, you look into the device and into the viewfinder to begin the testing. And what you'll see in there is on this green section in the middle here, this easy test takes place when you focus on the center dot, and then a bump will briefly appear and then disappear within the field of view that's being tested. And you'll use a mouse that's provided to click where you think the bump appeared, and you'll come back to the center dot, and then you'll repeat that process. Once you've completed the test for the day, your results are sent to our No Television Diagnostic Clinic, and they're evaluated and then provided to your eye doctor. And this is just a good, healthy habit to get into every day, just like you would brush your teeth, other good, healthy habits. But it's helping, of course, to preserve your vision and detect any changes earlier. 4C Home allows you to take this proactive approach to protecting your vision, and one of our clinical partners is going to be with you every step of the way for the setup process. Once our No Television Diagnostic Clinic receives a referral from your doctor, because it is a prescription that's required from your eye care professional, our team's going to answer any questions, verify coverage, insurance benefits, and then if you agree to move forward with the program, then we'll ship the device to you. And once you receive the device, then our diagnostic clinic, the same team members will walk you through the setup and the training. Like I said, they'll be with you every step of the way. And then as you're testing, you and your doctor will continue to receive feedback from our No Television Diagnostic Clinic. As I'd mentioned, our team's going to make sure to verify your insurance and your benefits, discuss with you prior to your acceptance of the program, anything out of pocket that you might have to pay as far as the monthly recurring payment. This technology, like I said, is FDA cleared. It is Medicare covered. There are low out-of-pocket costs for Medicare patients. Patients with Medicare and a secondary supplement could have no out-of-pocket costs. And then patients with Medicare without a secondary supplement plan usually pay around $15.06 per month once the yearly Medicare fee-for-service Part B deductible is met. But again, all this would be discussed with you prior to your accepting the program, wanting to move forward, and our team shipping you the device. So in summary, your doctor sends our No Television Diagnostic Clinic the order for you to begin the 4C Home AMD monitoring program. Again, appropriate candidates have a particular stage of dry AMD and a particular level of vision, which would be determined by your doctor. And then you continue to test regularly at home. If a change takes place, then your doctor is alerted and would have you come in for examination. So our No Television Diagnostic Clinic works with your doctor remotely to monitor your dry AMD and helping you retain functional vision throughout the years of your AMD journey. Thank you so much. For more information, you can go to our website, www.4chome.com. Again, here's my name and contact information, just my first initial, last name, MBLEMKER, at our company name, notelevision.com. There's more information as well on the Macular Degeneration Association website about 4C Home. And we are just thrilled to be partnering with such a wonderful organization. And I thank you again for your time and for joining today. Happy to take any questions that you might have about 4C Home. So just go to my Q&A here. There's a question about arthritis and using the 4C Home program. Wonderful question. So the requirement technology-wise is to be able to use a mouse. So as far as your comfort level with that, that would determine if you would be able to move forward with the program. What we can certainly do is after we have discussed 4C Home with you and received the prescription from your doctor and you've agreed to give it a try, we would ship you the device. Our team would set things up with you and you could certainly try that. And if for some reason you're not able to do the test, then we would be happy to take the device back from you. So this is not an obligation to be a part of the program, but we're very proud to offer this service to support what you're doing already for your AMD. But you can definitely, if something changes, you're unable, you can send it back to us. We would make arrangements for all of that. How much is the program? So you're essentially loaning we're loaning you the device, you're borrowing it, and you're using the device at home. So you don't have to purchase the device. Our team of our benefits and verification would take all of your insurance information, and there are so many insurances and so many nuances with insurance that our team would actually go through all of that first and then call you to follow up with that information, make sure you're comfortable with what, if anything, that you might have to pay. But our averages, most patients are Medicare patients, so the vast majority of our patients are covered. And then there's just a small percentage that have to pay something out of pocket. And that average out of pocket number is around $15 per month. Do we have a Canadian program? At this point in time, we're only able to offer our 4C Home AMD monitoring program within the United States. How can I get my doctor to get me this machine? Again, you would have to have an appropriate level of vision and an appropriate stage of dry AMD. So I think the best course of action would be to go back to your doctor with this information that's been provided and let them know you're interested and see if you're a good candidate for a 4C Home. Can I use this technology to monitor my wet AMD? This device is actually only designed for scientifically by the artificial intelligence and the algorithm that it uses. It's only for dry age-related macular degeneration and that conversion to wet. Another reason that it's only for the dry form of AMD is because that's the only indication from the FDA. Thus, the only approval by Medicare is for the diagnosis of intermediate dry AMD. Are there ever false positives? Absolutely. As with any technology, you'll have false positives and false negatives. This technology should be viewed as one more tool in your toolbox. Add this to all of the other things that you're already doing to take care of yourself and take advantage of technologies and treatments and monitoring, other steps from your doctor that they have recommended, any type of protocol or follow-up that they recommend. But as far as the false positives, there was a big study that was done for 4C Home. It was called the Home Study, done by the National Eye Institute. And that study found that there was usually one false positive for every 4 years per patient in the study. So it does happen, but the worst case scenario is it's an inconvenience for you to come in to see your doctor, for them to be able to just touch base with you, make sure to examine you, see if anything has changed at all, and then get you back on your testing with 4C Home. Is it easy to use if you have vision loss? As far as the level of vision loss and the different changes that can take place within this area that we're checking on the macula, of course, you'd have to have a visual acuity, that VA, of 20/60 or better. Most times we reference a visual acuity of 20/40 or better. I'm sure many of you have heard of these numbers. The higher the number means the worse the vision. That number on the bottom. So to actually take the test, you have to have this certain level of vision. And then if you happen to have different changes within this area, that we are testing changes in your retina, then the algorithm or the artificial intelligence will actually determine that over time. So the best thing to do is, if you accept the program, start testing, and then it would be able to determine what's normal for you as far as your starting point or your baseline. And then the algorithm or the artificial intelligence would just monitor for any changes from there. So how many patients have converted to wet from dry and caught in time? These are something that we call celebrating the catches, when we catch a detection from dry to wet. If you're able to follow us on LinkedIn or on our website, we have some information about these catch cases. Of course, I always feel like it's bittersweet because there is, of course, a conversion to wet AMD, and that means a totally different course of action if you're the patient and you are the one now going in for injections and follow up a little more frequently. But the wonderful part of it is that we have caught it early, can preserve your vision, and you can get prompt treatment before that significant vision loss has taken place. So it's always nice to catch cases early and be able to help you out. That's you're the heart of our company, and it's just a privilege to care for patients. All right. Great questions.